Welcome
Thank
to
you
the
and welcome.
215Q Alliance webinar. Thank you for joining us today. Today, Orrin Devinsky from NYU is joining us to discuss the use of cannabinoids to control seizures. Dr. Devinsky is currently conducting a study which includes several Duke 15Q Alliance families, and he's here to report his findings. He will be taking questions at the end of his presentation. One item of note, all of you are currently muted. This means that you can hear us, but we can't hear you. If you'd like to ask a question, you need to type it into the question box on your screen. And now I'll go ahead and turn it over to Dr. Devinsky.
Thanks so much. I will be giving an overview of the history of cannabis-based products to treat epilepsy. So to begin with, the history of cannabis goes back a long time. And just so everyone knows, cannabis is more of the biological term for marijuana. Marijuana was actually a slang term for cannabis used by Mexican Americans in the early half of the 20th century, and was incorporated by the U.S. government actually as a term, and then more widely. But going historically, cannabis has been part of human domestication and use for probably about 10,000 years, beginning in China. And it was used for rope, garments, bowstrings, paper, and then subsequently for medicinal purposes. We don't know exactly when that was, but by 2700 BCE, it was listed as a treatment for at least 100 different disorders in ancient China. And then its use spread, as this slide shows, really throughout the classical world, to Africa, into Egypt, to India, to the Middle East, and then to ancient Greek and Roman countries, and subsequently to the Arab Empire when that was dominant in the Middle Ages. And it again was used for an extremely wide variety of disorders, including epilepsy, going back at least about 3,800 years from the present time. So was a potential recognized therapy literally for 4 millennia for epilepsy. In talking about cannabis, it's a complex topic because there are several species which have now been interbred and their genetics are quite intertwined. But there are also over 500 unique compounds in cannabis. And the most prevalent and most interesting of those compounds are the cannabinoids. They are a family of compounds that have a 21 carbon specific called a terpenophenolic group as a skeleton, and then a lot of modifications off of that skeleton which give each different cannabis compound its unique properties. The two species that are most commonly referred to are sativa, which is the oldest one that we know about and dates back to China from the 8,000 years BCE, and then indica, which was written about in ancient Indian texts going back to 1700 BCE. And interestingly, it was the indica form that was imported through the British into Europe in the 1700s and 1800s that saw use throughout Europe and the Americas during the 1800s and early 1900s. In general, sativa plants are thought to have more of the THC, and that's tetrahydrocannabinol, which is the psychoactive compound in cannabis that typically is thought to give the high or psychoactive properties, whereas CBD, which I'll be spending a lot of time talking about, is cannabidiol. And when the ratio of THC to CBD is higher, you tend to get definitely more psychic and stimulatory properties. In the indica strains, it's thought that the CBD is a bit higher, so they have a little bit more relaxation and sedative properties. Again, as I said at the beginning, these are not in any way simplistic. These sativa and indica strains have been intermixed and interbred tremendously, and as many people know from states that have medically approved marijuana or cannabis, there are multiple different strains available that have different chemical properties. So what do we know about its use in the United States? Well, it goes back, as I said, for quite a while. We're a British colony, and so we got British medications, including cannabis indica, and it was listed in U.S. dispensaries going back at least to the 1850s. And in Ohio, in 1860, a committee on cannabis indica listed it for multiple neurological problems, including pain, hysteria, delirium tremens, mania, infantile convulsions, spasms, etc., and specifically epilepsy. So here again, we have specific historical reference to cannabis. Of course, the evidence and the data for this was limited. Sir Gowers is one of the most notable figures in all of neurology in the 19th century and was often considered the father of British neurology, and wrote a monograph on epilepsy, which is one of the most important historical books. In there, and in his chapter on treatment, he describes one patient in great detail who he prescribed cannabis indica for treatment of his epilepsy. He was a 40-year-old man who had seizures. They were called fits back then. They still use that term in England sometimes for convulsions. But he had them for 25 years, and he had about one tonic-clonic seizure every 2 weeks. This man was treated with bromide, which was back in the 1880s the only really known effective drug for epilepsy. But he stopped coming to the clinic. He stopped using the bromides, and seizures came back. When he returned, again with seizures, potassium bromide was reinstituted, but had no effect in controlling seizures when it was started again. At that point, Gowers prescribed the cannabis indica, an extract, 1/6 of a grain, 3 times daily, and this man went seizure-free for 6 months. Unfortunately, again, stopped coming to clinic and taking his medications, and again, seizures recurred. He was started on the Indian hemp once again, or the cannabis, and became seizure-free for months until Professor Gowers was on leave from the hospital, and another physician who was substituting didn't approve of cannabis or hemp, and so substituted bromide. The seizures recurred. When he returned 6 months later and saw the patient, he reinstated the cannabis, and he went 2 months seizure-free, but on the 3rd month, seizures recurred, and the patient never returned. So we have not convincing, but suggestive evidence, and this is a detailed case history, whereas other people may have said it worked. Here we have a patient who was treated with bromides, had tolerance, and when it restarted, it didn't work, and that's a common story, and then was prescribed cannabis, and from someone who was having seizures once every 2 weeks, he went 6 months seizure-free until he stopped the medication. And then again, it gave him 2 months seizure freedom, so suggesting at least there was a partial response in this patient. So in modern times, from this poster of Reefer Madness, the movie, I think everyone knows that the United States has gone through multiple phases in its interest and attitudes towards marijuana. The 1937 Marijuana Tax Act actually introduced that term, as I said before, marijuana. And one of the reasons they used the term marijuana is because no one knew what it was. Everyone called it cannabis in the United States at that time. And part of it was literally a ploy by the government to get this act approved. The American Medical Association opposed the act because it actually started to tax doctors for prescribing it, which essentially meant for sure that they were not going to do that. And they opined, I think reasonably, that marijuana has largely unknown but could have important uses in medicine. Unfortunately, the door essentially slammed down on the medical and scientific community in the United States at this time, and not much else happened for the next 70 years. In 1964, Raphael Mechoulam in Israel isolated delta-9 tetrahydrocannabinol, or THC, as the psychoactive substance. In the U.S., in 1972, THC was considered a drug with no accepted use. And then subsequently, Dr. Randall, for his own glaucoma, was able to get an investigational new drug application for cannabis to treat his glaucoma. And then in 1996, California legalized medical cannabis for AIDS and cancer. In the last 3 years, I think many people here are aware there has been an explosion of interest Charlotte's Web is a product high in CBD, which is made by the Stanley Brothers in Colorado. Sanjay Gupta did a several-part series on their compound and some patients who have responded to it, which received a lot of national attention on CNN. Here at NYU, we had a cannabidiol course several years ago, and from that we planned a trial, which the initial one of an expanded access, which just means an open label. The doctors know what they're giving out, the parents or patients know what they're getting, and that's been going on for over a year and a half now, and that's the one that at least 6 or more Dup15q patients have participated on. And then there have also been Dravet and Lennox-Gastaut double-blind placebo-controlled trials, which are now ongoing with Epidiolex, and there are 2 other companies, Insys and Norvigant, who are currently pending applications and initiation of their trials for cannabidiol to treat epilepsy. So what are the clinical data? Well, as I've said, we have from people like Gowers anecdotal data, and we've been getting that data for more than 150 years. As far as high-quality scientific data, we have very little right now. There were 4 randomized placebo-controlled trials involving a total of 48 patients, which used CBD as the treatment. In all of these studies, the existing anti-epileptic drugs that the patient was taking were continued, but unfortunately, because of the small number of patients, the methodological problems, everything from the blinding may not have been adequate to the administration of the medications had some issues. So the reports were considered of, unfortunately, low quality, and essentially no conclusions could be drawn. It did seem from those studies that cannabidiol was relatively well tolerated. A bit of tiredness occurred in some patients with no other significant side effects reported. So that may be the most data that can be gleaned from these trials that were done largely in the 1970s and 1980s. And this summarizes those 4 controlled CBD trials that were done. And as you can see, the numbers in each of the trial were small, and the methodologic issues, without getting into them, are significant in that paper that I referred to in the previous slide by Gloss and Vickery in 2014, which was a Cochrane database review, concluded that really there's just no conclusion about effectiveness that can be drawn from these studies. So what do we know about animal studies? And animal studies are much easier to do. Animals can be controlled obviously much more readily than human subjects. So there are many studies that have been done with THC, CBD, as well as some other compounds derived from cannabis or synthetic agents. And to start with THC, and this is just a summary overview, there have been 6 species studied, 31 different models or designs, so there are many ways to study the effectiveness of a compound or drug in animals. For epilepsy, we could give the animal an electrical stimulation to the head, which will induce a seizure, and see if the drug prevents that. We could administer a chemical, such as pentylene tetrazole, through an injection into the systemic system, so it gets to the brain, and that will cause seizures, and see if drugs prevent that. And there are many, many other models. So literally, THC has been tested in 31 different conditions, models, and designs. And the summary is that it has anti-seizure properties in 60% of those studies. It has no effect in 30%, and unfortunately, actually tended to cause seizures in 10% of those studies. Cannabidiol has been looked at in 2 species, in 21 different conditions, models, and designs, and it's effective in stopping seizures in about 80%, with no effect in 20%, and has never had proconvulsant properties, which is a very important finding, which suggests that we don't expect it to exacerbate epilepsy. There have been limited study on some of the other hundreds of plant cannabinoids or phytocannabinoids, and then there's also been some studies on CB1 receptor stimulants. As I'll get to, THC works on a set of receptors that exist in the brain called the cannabinoid receptors, or the CB receptors. And the CB1 receptor is mainly in the brain. The CB2 receptor is mainly in the immune system in the body. So it's the CB1 receptor we're interested in for epilepsy and psychoactive properties. And these are compounds that directly mimic the effect of THC, and they also can have anticonvulsant properties in animal studies as well. This is another way to look at the data, which was done by a colleague of mine here at NYU, Evan Rosenberg, and this has actually just been published in Neurotherapeutics. But again, it looks at the breakdown between the anticonvulsant effects in animals, which is in green, the proconvulsant effects, which are red, mixed effects, which are purple, and no significant effects, which are yellow. And you can see CBD and CBDV, which is cannabidivarin, which is another related compound to CBD, are either very anticonvulsant in the majority, and a small number of studies showed no effect. Delta-9 THC, some proconvulsant, some mixed effects, but overall mostly anticonvulsant with a modest no effect. But then when you get to the CB1R antagonists, these are drugs that block this receptor in the brain, you get a fair amount of proconvulsant effects, which makes sense since THC is stimulating those receptors, and the same for other drugs which stimulate those receptors. And overall, other drugs that modulate the endocannabinoid system, and that's the endo means internal or inside, cannabinoid means the system. So these are drugs that modulate the body's own cannabinoid system, which is mainly the CB1 receptors. And those are, again, either tend to be anticonvulsant or mixed in their properties. This is a slide from a paper that was just published in the New England Journal by my colleague Dan Friedman and myself. And this shows the structure of the three cannabinoids for which we have the most interest in treating seizures: delta-9 THC, cannabidiol, and cannabidivarin. Cannabidivarin may well be a drug that is of interest and will be studied in the coming years as a potential treatment. And on the right, not to get into any of the details here, but just to show you how complicated life is in the brain, these are where we know from some binding studies, animal studies, cell culture studies, these are places where each of these compounds bind to and what they do. Partial agonist means it partly stimulates it. Agonist means it fully stimulates. Antagonist means it blocks it. So these drugs have positive and negative effects on multiple receptors within the brain. Some of the ones that we're especially focused on are the GPR55 receptor for cannabidiol as one of its major anti-epileptic effects. But whether that'll be borne out with time, we don't know. There's a lot of research going on in animal and cell culture studies, and hopefully this will be worked out. But just to make the point, people talk about these things. These are drugs. These are derived from natural plants, without a doubt. But when you take plants by the pound and you distill specific compounds or concentrate the plant substance, it is a drug. It may be a natural drug, but keep in mind, nature makes many things, from poisonous mushrooms to snake venom to pufferfish, for which tiny amounts of nature's products can be harmful or even lethal. So it's called the naturalistic fallacy, and not to confuse something because it's natural as safe. So what do we know about marijuana and cannabis use from epidemiology? Not a lot, but there's one intriguing study that was done back in 1990 and reported by Eng from Columbia University. And they were looking at the illicit use of drugs and the new onset of seizures in Harlem. They looked at 308 patients in Harlem who had their first seizure and compared them to a similar number of control subjects without seizures, and found that heroin use was a significant risk factor for having a first seizure. An unprovoked seizure, the odds ratio was 2.8, and a provoked seizure, which means there was some other factor that provoked the seizure, was 3.6-fold greater in someone who was using heroin than someone who wasn't. What was remarkable about this study was that of individuals who were surveyed in the emergency room after a seizure, or similar patients who did not have a seizure, unprovoked odds ratios were 0.42, which means, and 0.36 if you used cannabis in the last 90 days. What that means for people who used cannabis in the last 90 days, they were about 3 times less likely to have had a new onset seizure than those who didn't. And for provoked seizures, it was actually about 5 times less for cannabis use. The Institute of Medicine reviewed this study 9 years later and felt that it was not by any means definitive because they didn't have health status before admission. So the argument was perhaps someone's health status may have influenced their drug use rather than the drug use influenced their tendency towards seizures. That is certainly a possibility, but certainly another possibility is that the use of cannabis truly did diminish the risk of a new onset seizure. It's certainly suggested by the data, but as I said, by no means proven. So as I referred to earlier, yes.
Orrin, if I can interrupt, a couple questions before you go too much further on that. One is, what's your view on the entourage effect and the value of using whole plant CBD versus derivatives?
So if I could hold off on that, I've got a few slides at the end of my talk to focus on the entourage effects. I will cover that in some detail. Perfect.
And another one says the DUP15Q population is known to have abnormal spikes on the EEG that aren't considered seizures. Would the cannabinoids potentially calm down these abnormal spikes?
It's an excellent question. The little bit of data we have on that to date comes from Colorado Children's Hospital, where they did look at EEGs on patients who had had them previous to starting a medical cannabis product, and then subsequently the parents started their children on a medical cannabis product and then came back to see the physician at some point later and had EEGs repeated, and their findings was that there was no change in the EEG. Now, that was a very limited sample size, and I would not say it was rigorously scientifically studied, but the indication is that it may not have a significant effect on the EEG. And I should also note that many of the anti-seizure drugs that are approved by the FDA do not have significant effects on controlling spikes on the EEG, whereas some like Depakote and Keppra and clobazam, also known as Onfi, can be helpful in reducing spike activity on the EEG. So the answer really is we don't know yet with cannabis products.
Great, thank you.
So going here, the original YouTube of Charlotte with Dravet syndrome, who was treated with Charlotte's Web. This slide is actually old. It was viewed 250,000 times, I think, within months of its uploading. It's probably over 1 million times at this point. And it led to tremendous interest in cannabis for treating epilepsy. So there's been interest in it for, as I said, close to 4,000 years. There's been scientific anecdotal data for 150 years, and then Charlotte brought it to the world in a way it's never been before. So there have been some surveys of people with epilepsy going back, just looking at the history. This is a study by Dr. Gross, published in a Neurology back about 10 years ago, and he interviewed 136 people at a major epilepsy center. Half of them reported some lifetime use of cannabis, 21% were active users, and of those, most reported it either improved seizure frequency or severity. None reported that things got worse. Elizabeth Gordon, who was a student at the time, and myself did another survey published a few years earlier in Epilepsia of 215 people, same thing, people coming in an epilepsy center who used cannabis intermittently or regularly. 90% actually told us they had no relationship to seizures with the use. 7.5% thought it lowered seizure frequency, and a little over 2% thought it occasionally made seizures more likely to occur. So again, these are just broad surveys. They're not scientific. They're retrospective recollections, which can have a lot of bias in one direction or the other, but just a hint. And then there was also an early survey reported of Charlotte's Web and other medical cannabis products in California and Colorado, mainly done by Brenda Porter and Kathy Jacobson. This was reported a couple years ago. There were 19 children whose parents were interviewed or surveyed. 16 or 84% reported a reduction in seizure frequency. 2 of the children were seizure-free, and I can tell you, I think Paige Figges was one of the people surveyed, and many of the early people were in this survey. 8 of them had a greater than 80% reduction, or 42%, which is huge, and 6 had a 25 to 60% reduction. So again, this is all open label. People knew what they were giving their children, so there's all the inherent risks of bias. They also found that there were some benefits that the parents reported: better alertness, mood, and sleep. The major side effects, again, just as was found previously, were drowsiness and fatigue. And the most common diagnosis in this population was Dravet syndrome with Duce and Lennox-Gastaut and idiopathic epilepsy, rounding it out. So as one of the questioners already raised, and I'll get to this over the next few slides, but there's a lot of interest in whole plant products and the role of tetrahydrocannabinolic acid, THCA, among many of the potential natural things for which there might be the entourage effect, which I'll discuss later on. So THCA is an acid form of THC. It's present in variable quantities in fresh, undried plant. It is progressively decarboxylated, a chemical reaction to THC, when it is dried, but especially when it's heated. So by smoking it, you turn THCA into THC. If you eat the plant material, it's not converted in the body so much from THCA to THC. The THCA itself is not psychoactive. It has been studied in some animal models to have anti-inflammatory and neuroprotective properties. Again, take these things with a grain of salt. Most anti-epileptic drugs on the U.S. market have been found to have neuroprotective effects. Many compounds have anti-inflammatory effects. It's just a question of which model, and there are so many models of inflammation that can be used. Interestingly, the government uses THCA, it shouldn't be V here, THCA, to distinguish Marinol, which is a synthetic THC, from cannabis use, because people who use the plant will have the THCA in their blood system or urine, whereas people who are taking prescribed Marinol will not have it. So it just speaks to the fact that, this is a compound of interest. I have to be scientifically agnostic because we just don't have the data. One thing that has occurred is that there have become a huge number of experts on medical cannabis. People who are sure that you need, and I'll get to this a little more later, certain amounts of THC or THCA or CBDV. There's just no data. And I just can't impress that enough upon people, that science is about understanding, and by the same token, I am very sympathetic to parents. If I had a child with Dup15q or Dravet syndrome who was having 5 seizures a day and had been treated with 12 anti-epileptic drugs approved by the FDA and the ketogenic or modified Atkins diet, and failed all of those therapies, and I saw Charlotte Figge's story on CNN that she was taking CBD and was seizure-free or nearly seizure-free, I would want to give it to my child, and I would understand that it may not be scientifically proven, but the risk-benefit would make sense to try it, and I would do that. Having said that, from the scientific point of view, keep in mind, people like Steve McQueen got on TV to say that Laetrile cured his cancer. He died within a year of saying that, and Laetrile was later studied in a large randomized double-blind placebo-controlled trial and was found to have absolutely no effectiveness in cancer. So things for which people are 100% convinced are often wrong. And that's true for doctors. Doctors are just as liable to bias. Parents are just as liable to bias. So it's hard to imagine how biased people are, and everyone underestimates it. So what are some of the other dangers of home therapy? This is unfortunately from the hand of a father whose young girl I take care of. She was treated in New Jersey, where unfortunately only whole plant material is available. So basically all parents, if they want to give an oil, are forced to make it themselves. And there are things like, I believe it's called the magic butter maker, which I think is safe, but this father was doing his own alcohol extraction from the plant material and unfortunately did not turn the flames on when he put the alcohol into the double boiler and sustained severe burns. There was one girl, at least again in my practice, who I didn't prescribe this for, who was given a high THC medical marijuana and for the first time in her whole life went into status epilepticus, an uncontrolled prolonged seizure, and had to get airlifted to a major medical center pediatric ICU. So again, keep in mind, like everything else, there are pluses and minuses. This is not to be scary, but just that one needs to just take a step back and just consider all of the potential issues. So what are some of the problems we've had as scientists, as doctors trying to study this? Well, I hinted before about the naturalistic fallacy. We started our Epidemiology study here at NYU about 18 months ago, and literally, almost before announcing it, had many, many hundreds of parents and patients wanting to enter the study. My colleague, Dr. Jackie French, who has some of the most promising anti-epileptic drugs in the world, one of them seems to be remarkably promising, and I hope it comes to market in a few years. She has to push, pull, and beg to get patients into her trials. So there's no doubt the fact that I think the hype of the CNN stories, the concept that for parents, this is something I did in high school and college and still do occasionally, and it certainly hasn't hurt me, and a little tiredness, and look at the medicines that I'm giving from that are approved, which is correct. The drugs that we prescribe that are approved by the FDA have a lot of side effects, and there's no denying that. But it doesn't mean they're safer or less safe. Until we do studies, we just don't know. There's also a very interesting phenomenon that there are high rates of placebo response with anything, whether it's chest pain or cancer treatment, and certainly in epilepsy. But what's interesting and for me was paradoxical and something I didn't expect was that the placebo response rate in children is actually higher than it is in adults. And this is true in epilepsy. It's also true in anxiety, obsessive compulsive disorder, ADHD, pain, asthma. So it runs across a number of disciplines. In a meta-analysis, which just means you take a large number of studies and pool them together in a scientific way of individuals with treatment-resistant epilepsy, it's fascinating that the children improved more with placebo, on average 20% for the children versus 10% in adults. So this goes along with exactly what's been found in medicine and pain and psychiatry, that in drug studies where everyone's blinded, the doctor, the parent, and the child, the placebo response rate's about twice as high when children are treated than adults. We can argue and guess why that is, but the simple thing is that that's been found across multiple studies and, as I said before, in multiple disciplines. In addition, children with intellectual disability and treatment-resistant epilepsy are also quite prone to high placebo response rates. So clobazam in the Lennox-Gastaut study, there was greater than or equal to a 50% responder rate for drop seizures using the drug, and it was over 31% for placebo, which was not statistically significantly different. Luckily, the average seizure frequency, when they just actually counted the number and not looked at how many had a 50% reduction, was significantly lower in the clobazam group, which is why it did eventually get FDA approved. But had they have chosen the 50% responder rate, which is a very common way for drug companies to pick a primary outcome measure, clobazam would not have ever been approved for Lennox-Gastaut because the placebo response rate was so high in this randomized controlled trial where neither the parent nor the doctor knew what the child was taking. And then there are, of course, concerns about potential harms from cannabis, especially the THC portion. So we know from human studies in adolescents and adults that THC can impair cognition, motor control, can lead in some individuals to psychiatric disorders, and long-term has been associated with altered brain development, a potential for addiction, cognitive impairment, and higher rates of long-term psychiatric disorders. So that again, this is from a recent review in the New England Journal of Medicine from people at the National Institutes of Drug Addiction. But, it's an important point that there are potential adverse effects, especially with THC. And I add to that the caveat that the long-term effects of the FDA-approved seizure drugs in children and adults have not been studied. Typically, 3-month trials are done to get drug approval, and then after that, everyone's unblinded, and bias and other factors can contribute. So we really don't know what the long-term outcome is from putting a child on topiramate or clobazam or any drug. We just have not collected scientific data. And then finally, there's the issue of perceived therapeutic benefit. There was a poll done by Epilepsia, and in short summary, when lay people are asked, is there enough data to show that cannabis is both effective and safe for epilepsy, the vast majority of lay people say yes, and the vast majority of physicians say no. And I call this a little bit of the science of convenience. I think everybody likes the part of science that gives them cell phones and computers and internet and getting up to the moon and exploring, nanogram technology. So that part of it we embrace as a society tremendously. But as many people know, 40% of Americans don't believe in evolution, despite overwhelming evidence before genetics, but with genetics, I would say it's remarkably overwhelming. In the same way, when it comes to things like cannabis, until there's a randomized double-blind controlled trial, we don't know. And even then, those studies are not always replicated. So science is about admitting you don't know. It's the opposite of religion. And again, nothing wrong with religion, but belief is belief, and science is proving it. And even when you prove it in science, down the road you have to expect that new data will come out and things you thought were proven are no longer correct. So science is about being humble, and religion's about belief, and you just need to separate the two of them. So let's touch now briefly on the entourage effect, because it's an interesting topic historically and scientifically. So Ben Shabbat and Meshullam from Israel, the original isolators of these compounds, found that there were some endogenous compounds in the brain, which one of them is called, just simply call it 2-AG. And it's a compound made by the brain. It's found in the brain, and it stimulates both the CB1 and CB2 receptors, which are present in the brain. So it's called an endogenous cannabinoid produced by the brain. That's why these receptors exist, because compounds like 2-AG are produced by the brain, and they stimulate these receptors. In the same way, there are endogenous opiates that stimulate the opiate receptors, and plant compounds like opium will also stimulate those receptors, similar to THC is doing for the CB1 receptor. So what they found early on were that there were other esters in the brain and the spleen, again, without getting too detailed, call them 2-LG and 2-PG, and that these esters themselves, these compounds which are present in the brain and the spleen, they don't bind to the CB1 or 2 receptors, and they don't work on the next step in that pathway that those receptors mediate. But what they do is if 2-LG or 2-PG are present with the endogenous cannabinoid 2-AG, they potentiate the effect of 2-AG. I'm sorry if it's a little complicated, but essentially these are compounds made by the brain that don't directly stimulate the CB1 receptor, but they make the compound that the brain does make on that receptor, 2-AG, they increase the activity of 2-AG. They make it stronger. And that's the entourage effect. I can't say it loud and clear enough. That's the entourage effect. That is what Meshullam and Ben Shabbat described as the entourage effect. The fact that you can get these compounds together that give a greater response on the CB1 receptor, and yet paradoxically these other two compounds don't stimulate CB1 receptor themselves. So for everyone who wants to know, this is the slide, and this is the study and the reference for what the entourage effect is. Nowadays, the entourage effect has been used in an indiscriminate way and can refer to everything under the sun. So how has it been hijacked? It's been hijacked by the botanical and medical community. So well prior to the interest in Charlotte's Web, there are phytocannabinoid and other compounds that are made by botanical companies that saying when you mix these things together they work better, but there's no data and it's easy to test that. And then it's also been hijacked by commercial pharmaceutical companies that if you mix compounds together you can get protective effects, and there actually is some evidence on that. We know that CBD minimizes the psychoactive effects of THC, but it's not the entourage effect. It just happens to be that CBD, if you use it with THC, you'll get less of the psychoactive effect of THC. And then the entourage effect has been expanded to mechanisms of interactions, classes of compounds. But the idea of synergy is a relatively straightforward concept. It's widely used in the botanical medical literature, often without any rigor. These are very easy experiments to do. If you want to show synergy, that is, two things work better together, which is, I think, how many lay people interpret the entourage effect as it's promoted by the medical cannabis industry, it's very easy to do. So, for example, you can show two plant cannabinoids like CBD and CBDV. When you put them together in a model of, let's say, epilepsy, they're additive. They're not synergistic. You don't add 1 and 1 and get 2.5. You add 1 and 1 and get 2. So they're not synergistic. And you could take any of the plant cannabinoids and test them in seizure models like THCA or THC. It's not yet been done for epilepsy. It could be done in animal models, but it's not been done. So we don't know. And anyone who says they know, I would just ask them to show you the data, because it certainly hasn't made it to the scientific literature yet. And then again, just finishing up on the entourage effect, what are some of the mechanisms potentially by which you can get synergy? Well, there are things where there's pharmacokinetic effects. You can improve the solubility or the bioavailability of a compound. So by mixing two things together, more of it may get into the blood system or may get into the brain or nerve cells. And then there are other ways. Cannabidiol and other terpenoids can share precursors. The terpenoids are very potent and can have effects on animal and human behavior when inhaled. So there are a lot of ways these things can affect. I mentioned the antagonism of CBD and other compounds to reduce the psychic effects of THC. Some of these compounds, like CBD, can affect the enzyme that breaks down THC, so again, could affect THC by that route. And then these interactions or synergy have been claimed to treat pain, inflammation, depression, everything under the sun, but the data for them is really quite limited. So with regards to epilepsy and the entourage effect, CBD and THC, I think all the scientists agree, have quite different mechanisms of action. They may act synergistically control seizures. There's such minimal data at this point, the answer should be we don't know. And keep in mind, people, the other thing that just to understand is that take it back to evolution, which is how these plants emerged and why they got so many compounds. They didn't get 500 compounds to treat human epilepsy. They didn't get 500 compounds to do anything for human beings. These compounds, as best we know, were not part of artificial selection or human breeding. These were things the plants came up with themselves. And they did it potentially to increase their fitness or reproductive capacity. They did it to protect themselves against parasites or grow better in adverse situations. But they didn't combine these compounds together to treat epilepsy. It could turn out they help epilepsy. It could turn out they don't. It could turn out they cancel each other out. We just don't know. But until we do it, until we do the studies, we just don't know. So, this is a quote, new research, what has long been thought CBD in addition to other entourage cannabinoids like THC is far superior medically to pure CBD. And that's the equivalent of me saying, the line down the center of your palm means if it's more than 3 inches, you will live a long life. There's just no data for either one. They may be right. Both of those statements may be right. But as of now, I'm not aware of any data to show either of them are.
And so I got a couple questions here, if I can. Or you want me to wait till after you do the conclusion?
Yeah, this is my last slide, so I'm just going to finish here, and then I'll take all the questions. And I just have 3 people pictured on this slide. One is Coleridge on the right, from his famous poem, Water, Water Everywhere, nor any drop to drink. We've been thousands of years as a species using cannabis medically, and we feel like we know a lot, but we don't. Meshulam, who first isolated THC and CBD, is pictured up there on the left, who's still active in Israel doing studies. And so I just think we should all be humble. We need more scientific data. And one of my many heroes is pictured on the right, Richard Feynman, who won a Nobel Prize in Physics. And he had many quotes along these lines, but as he said, I'm smart enough to know that I'm dumb, and I feel the same way. So I'll stop there and leave it open for questions.
Okay, great. So the ones that I have so far are, what is the effect of inhibiting adenylyl cyclase?
Adenylyl cyclase is what's called a second messenger, and so many receptors in our body and in our brain work when a compound binds to the receptor on a cell membrane. That triggers something in the cell, and adenylyl cyclase is often a second messenger. So it's a biochemical reaction that mediates the effect of, for example, the CB1 receptor. It's complicated. It's not a simple answer, but it's essentially what we refer to as a second messenger. It's the next step in what may be a multi-step pathway.
Okay. Are there any studies about juicing whole leaves versus just using the oils? Could other photochemical in a whole plant be working synergistically with CBD?
Absolutely no data, no idea.
Okay. Can you tell us any details of your Epileptics trial with Dup15 kids? Is it working?
Yeah, so I think my experience with the Dup15 patients has been fairly similar to my experience overall with the broader group of treatment-resistant epilepsy, and that is that I think there are, so far we only have data from the open label study, so these are patients that I know what I'm giving the parent and the child. The parents know what they're getting. They know the concentration of milligrams per milliliter, so it's not blinded, and this would not in any way fit the criteria for rigorous scientific data. It's more experiential to give us an idea of a signal of what may be going on, but understanding we don't have answers per se. Having said that, I would say solidly, 60%, 70% of parents have reported a substantial decline in seizure frequency. It's uncommon for the children to be seizure-free, and if they're having frequent seizures, it's very, very uncommon. I have had at least 1 or 2 excellent responders in the Dup15Q group of about 6 patients that I've treated. So there have been some excellent responses with pure CBD in Dup15Q, and other ones have responded partially. So, it appears to be a promising drug. Given that effect, again, these children did not respond to many, many drugs before they had a chance to try the CBD.
Okay, thank you. Have one that's asking about a particular state. You may not know about particular states, but it says in Massachusetts is the only access to CBD through clinical trials.
I just wouldn't want to comment in Massachusetts. I apologize. I just don't know each state's laws.
Yep, each state's going to be way different on those. Okay, so here's one, somebody with a 25-year-old idic son who's been having some seizures, did some CBD, THC oil, approved in Minnesota, had reduction in seizures first 5 weeks, then slight increase. would like to know if a reset helps. Reduction or stopping oil and allowing body to reduce oil, does the reset or reduction going to make a difference?
Well, I think we've seen in some patients, which I must say I've seen with every anti-seizure drug, some tolerance, especially in treatment-resistant patients, so that unfortunately you get this tease or honeymoon effect where the child, has a nice reduction for a period of time and then seizures kind of wind back up a bit. There's no good answer taking them off and putting them on, taking them off and putting them on. I think unfortunately, that can work for a brief period of time, but it's probably not a great strategy long term.
Okay. They're bouncing in here so fast, they're bouncing out of my screen now. So hang on one second while I get back to it. Okay, if adenylyl cyclase is inhibited overall, it doesn't seem specific to C1 and C2 receptors. It would be affecting systemically? Would that be correct?
Well, yeah, I wouldn't use the word systemically. So we use the word systemically to mean the whole body. So it might be the whole cell or something. So keep in mind the way these things work is that these are specific receptors on specific cells, often on specific parts of nerve cells, like the cell body, on the axon, different parts of it, so that they cause local effects in the internal biochemistry. So they can be fairly specific because that adenylyl cyclase is activated very locally in a specific pathway. It's complicated. Again, for anyone who's interested, they can Google adenylyl cyclase and read a little bit about the biochemistry of second messengers.
Okay. I think this one's looking for kind of a recommendation, not professional maybe as much as personal, but should we be waiting for a clinical trial in our area, or do you think trying something like Charlotte's Web is reasonable?
I think for a parent whose child has poorly controlled seizures, my understanding is that Charlotte's Web is shipping now to all 50 states. I have a fair number of patients who get it and use it. I can't say I know 100% that it is 50 milligrams per mil, which is what it says it is. I don't have a lab to test it. I think the people making it seem to be reliable, but again, that is a gut, not a scientific response. But I think for parents whose children are having ongoing seizures despite available therapies, including diet and the FDA-approved drugs that are likely to work, I think it's an option to consider.
Okay, thank you.
I think you should tell your neurologist, because there are drug interactions. If your child's on Onfi or clobazam, there's a metabolite called the endesmethylclobazam metabolite, which can be significantly elevated when using CBD or Charlotte's oil or web, and that can, cause significant side effects of tiredness or sedation, or could cause improvements in seizure control, which is not directly due to CBD, but is really due to the Onfi or clobazam.
Thank you. Are there any studies done on cannabis and Fycompa, a fairly new drug?
Not to the best of my knowledge.
Okay. And should blood results from before cannabis and over 1 month on it show changes in an anti-seizure drug?
Well, yeah, they can. So we're still analyzing a large number of data on this. The one thing that's very clear, as I said, that if a child's on Onfi, and I think LabCorp does this, you need to get the metabolite level measured before and after the child's on the drug. And then potentially valproic acid or Depakote levels may go up while on CBD. So I do think it's a very good idea to get baseline measurements of the drugs and then repeat them like a month after or 2 to 4 weeks after starting any of these products.
Okay, great. Those are all the questions that I have, Orrin. So any final words that you'd like to say?
No, I think it's an area of great promise. I believe we'll get a lot more scientifiq data in the coming years, and I hope this proves to be a really effective and great drug for children with Dup15q and other individuals with epilepsy. Great. But we need to see.
Yep. Okay. Well, thank you, Orrin Devinsky from NYU, for I think a wonderful hour here talking about this topic, and I think you made it pretty understandable for even people like me. So I appreciate that very much. Thank you, everybody.
Okay. Thanks, everyone.